Good evening, everybody. So I'm Dr. Harmandeep. So you are welcome in this CMA. So here we are with the last topic, and I will not take much time. It is about the OADs. So here we don't have specific guidelines. We have some data and some expert opinions on it, and more experts, they are suggesting that we should use these OADs in hospital settings also. All the time we are discussing about insulin and management, so all the guidelines also, they are about the insulin. And insulin is something where you don't have to apply much brain to individualize the treatment. You just see the numbers and you adjust accordingly, although there should be some protocols to follow. But when you are thinking of OADs, here definitely you need to individualize the therapy. So because we don't have specific guidelines, so we will have to make our own consensus. So why there are no guidelines? Because for most of the time we had only metformin, and we were always worried about lactic acidosis. So that was a big worry. So it was never allowed in hospitals in acute illness. The second thing was we had sulfonylureas all the time, and we always knew that they increase the risk for hypoglycemia, and that is also a big worry. So they were also not allowed. Then there came these new drugs. They were DPP-4 inhibitors, and now we have SGLT2 inhibitors. But definitely you take time, you need time to assess their efficacy and their adverse effects when you make some guidelines. And we are hoping, like with all the experts recommending them in patient setting, that in near future we will have some guidelines around that also regarding the OAD part. But definitely that will need a lot of brainstorming, because where will you allow and where will you not allow, because there are some things associated with them. So here I think we are all practitioners here, physicians who are dealing with diabetes all the time. So I think we should have our own consensus also, like what we want to do with these OADs. So so as we all know, most of the guidelines till now, they are suggesting that all the persons should be on insulin and ICU, whether it is infusions or sub-Q basal bolus. And we are discussing whether we should use OADs as well. So we will start with the first case. So here this case came actually online, and everybody was to opine around about it, like whether what do you want to do with this patient. So you see, this is a 72-year-old female, 5 years of diabetes. She was well controlled on metformin. Her HbA1c on admission was 7.7, I think. So she is having fever. She has some lung patch. She has pneumonia, community acquired pneumonia. She was put on IV antibiotics. She had fever. So her oxygen saturation was 88%. She was hemodynamically stable, but her oral intake was poor. So otherwise, if we see her reports, her KFT, LFT, everything was normal. She was admitted in the hospital. So as everybody mentioned, like what do we want to do? So first of all, we want to see, like, first is the medication. You always ask what patient was taking. She was on metformin. She was taking 500 milligrams twice a day. Then you want to know, like, how was her glycemic control when she was better, she was at home. So HbA1c came around 7.7. So now is the question, like, do you want to use OAD, or you want to stop metformin, or you want to continue metformin? So metformin is a kind of very controversial thing. Like, always we are afraid of lactic acidosis. And so what would be your opinion? So options are to continue or discontinue, obviously. So these two things. So I think you can raise your hand who are with metformin. Yeah, so who want to discontinue? Okay, so not many people are raising their hands. Okay, so what we all the time were doing was we wanted to discontinue metformin, right? So here the surprising thing was that 60% people, most of them like intensivist as well actually, so they wanted to continue metformin. So 40% people were in the favor of discontinuing it. So what were the factors actually? So why people wanted to continue metformin? So you all know, so metformin, when you discontinue, every diabetologist who practices actually diabetes know that in many people, whenever we stop metformin, glycemic control becomes worse. It is very difficult to control actually in many patients. So some people come with GI upset, with diarrhea or something, you have to stop metformin and then you struggle. You put all the OADs, the control will not never be same. And many patients prefer to go back to metformin, whatever their GI upset is. So people think like metformin is one thing which is working at the pathophysiology, it is reducing the resistance, and when you stop it, your glycemic control worsens. The second, so insulin, for most of the patients, that is a burden. Like whenever we stop OADs and we counsel patient like you have to be put on insulin, it takes hours actually for educators, for our DNB residents, and for us also, like convincing patient that for some time you have to be on insulin. After that we will restart your OAD, but that takes a lot of time and it is a burden for hospital care staff as well. All the time they are struggling with insulin checking and just like making it feasible that you give insulin according to the meal. So what evidence we have? So we have used metformin for decades now, and there has been good evidence that the incidence of lactic acidosis is not that high. So we have a big Cochrane database. So there are like million patient years studied with metformin in all the situations, in you can say altered renal function, in altered pulmonary function, in cardiac failure as well. According to that, the chances of having lactic acidosis when you continue metformin or discontinue metformin, they're almost similar. As you can see, with metformin it is 4.3, and with when you discontinue it is 5.4. So the chances of lactic acidosis are comparable actually. The lactic acidosis which we see basically is thought to be because of the underlying disease process as such, not with the medicine. So this is one big thing with lot of data. There is one published data also about the US hospitals. Actually, although these OADs, they are not advisable, but they are being used in all the hospitals we know all the time. In US also, they saw like 30% patients, they remained on OADs actually in all the peripheral hospitals, and they got actually good data from there that there was no increased chances of lactic acidosis. So then now we have, then all the cutoffs were also reduced, like you can use metformin in CKD3 state as well. Then in CHF also the things became more lenient, like you can use metformin. So regarding the option 2 actually, so the people who wanted to discontinue metformin, what was their suggestion? They were like, still there are no recommendations. We don't have any compiled data like till what stage we can use metformin. The next was like patient is old, she's 70 years plus. Actually, she is diabetic, she has pneumonia, right? So she can worsen anytime. So she can go into sepsis, she can go into AKI, she can land up in lactic acidosis. So they didn't want to give it. So, and the important part, like her oral intake is poor. So the people who wanted to discontinue metformin, they didn't want to actually irritate the GI, they didn't want to increase gastritis and all. So the people who wanted to give metformin, they told like, person's intake is already poor. If you start on insulin, there are higher chances of hypoglycemia if you inject wrong doses, or maybe patient doesn't eat or vomit or something. So, and because we all know in all the infections there are chances of stress hyperglycemia, obviously you will have to start insulin somewhere, whether you continue or discontinue. Okay, so this is our own hospital data. So regarding same the problem of lactic acidosis, because here we do continue metformin till the day of surgery. So we wanted to have some own data, although there are published trials, long list of trials, who used metformin before surgery with good results. So here also we had similar data. We checked the lactate levels post surgery. So there was no significant difference between people who continued, who discontinued, and who were the controls, like people without diabetes. Now the next case, so this is a 73-year male. He's diabetic for 6 years, and he has undergone knee replacement. Again, all the parameters good. Patient is stable. He's eating. All organs, they are fine. So it is post-op day 2. You are called. You had given the clearance for the surgery, and you told them you can continue metformin. So again, so patient was on metformin 1.5 grams daily. So these are his readings, like fasting 150, 162, and preprandial readings. They're going up to 180, and the surgeon wants a better glycemic control because patient is old, diabetic, knee replacement. He doesn't want any infection. So what would be the next thing? What should we do, right? So here we are. One option is to go for basal bolus therapy, again, which is recommended actually. Other than that, what else it can be? So do you want to give sulfonylurea? Of course, no, because he's an old patient. Post surgery, glycemic control was good before surgery, and we are worried like sulfonylurea can cause hypoglycemia. So obviously, I don't think anybody would like to start it. So next, another group is there, TZDs, although they are not any favorite now. And the important point here is that they take long time to show their effect, so they are not good for inpatient setting. So DPP-4 inhibitors. So do you like to start it? So this is one drug which doesn't have, this is kind of a good drug which doesn't have many side effects. Almost no, I would say. Soft. They don't cause hypoglycemia, particularly when they are combined with metformin or used alone. And for mild hyperglycemia like this, they are like quite suitable drugs. So what about SGLT2 inhibitors? Do you want to start it? So maybe some people would, but I think patient is post-surgery, old, he will be undergoing physiotherapy, he will have to stand, he will have to do some exercise, walk. We don't want any like dizziness, and we don't want him to go to toilet all the time. So he will be in a fix. So do we have some data regarding DPP-4 inhibitors? Yes, we do have. There are some, initially there were pilot trials, and then there was this good trial, CETA hospital. So sitagliptin was used in medicine and surgical wards with good results actually. So, so two groups were compared, one on basal bolus as usual, and the second one was on sitagliptin plus basal actually, and correction doses were used whenever required. So if you see the glycemic control, it is, if you see the mean glucose over the days post surgery, so during the admission they were almost equivalent. And if you go for the daily variability, so it is same whether it was basal bolus or it was CETA plus basal insulin with correction doses, of course. So similarly, we have trials with linagliptin as well. So this is the post-surgery group, Lina Surge study. So here also the data was typically similar to sitagliptin. Same thing was used, either basal bolus or linagliptin with basal insulin plus correction doses. So data is similar. Similar trials are there with saxagliptin as well, and the results are showing there are no adverse effects that we all know, and the glycemic control is almost similar. So there are some little bit, like we all know that pancreatitis, risk of pancreatitis, that is there, not use, and there is saxagliptin story, which is a sad story, that there is some risk of heart failure, maybe, we are not sure, but it is not recommended. So what about SGLT2 inhibitors? We will not take long because there is lot of supportive data. Everything is coming good about SGLT2 inhibitors, but whether they can be used in hospital setting, we are not sure right now. So we need more data to be sure that there are no adverse events. So what we have is, so one trial we have that was done during COVID-19 actually. So the first one which appeared in diabetes care. So this was a positive trial. Actually, the people who were on SGLT2 inhibitors, they did well. Actually, there were lower chances of decay in these patients. But on the same side, DARE 19, where they used actually SGLT2 inhibitors in hospital, the patients who were admitted with respiratory failure with COVID-19. So the data was not good. They had many of the patients, they had decay, but data was extrapolated actually because there were very few patients. So not a good study otherwise. And what we have is heart failure. We all know there is a lot of data coming out. The trials on OPD settings were there, but in hospital there is Impulse trial, which has shown like there is no excessive adverse events noted as compared to placebo. So the patients, the heart failure patients, they did better actually. So their the events, they were lesser, their mortality was lesser, hospital stay was lesser, and the post hospital recurrent admissions with heart failure were less. Again, this study was just in 560 patients or so. So this is one study going out in our hospital also. We are also watching like whether it can be used in hospital setting or not. This is in the post cardiac surgery patients basically. So we have some data. First 15 days data is there with us with most of the patients, and there are no decays, at least we have not detected any. So take home messages: in mild to moderate hyperglycemia, so that is the condition. So if patient has severe hyperglycemia, obviously insulin is the solution, but in mild to moderate cases we can think of OADs. DPP4 inhibitors, they are safe to use. We have good studies to and then metformin. Metformin, if there is no major organ dysfunction, obviously we can consider it. Sulfonylureas, definitely everybody is saying all the guidelines, it should be avoided. And SGLT2 inhibitors, more data is coming. We should wait a bit, and maybe we have some indications for in-hospital setting as well. Thank you.